you get wise, get up and get out. Get rid of that frown that's been dragging you down and get up in the air. Just pretend that you can fly. You'll never know if you can till you try.
Hi, and welcome to Cannabis Helps Dementia. I'm Chella.
I'm Dave, and right up front, we'd like to say that we're not doctors or medical professionals, and nothing you hear in this podcast should be considered medical advice.
Right.
Yeah, we're not experts, but throughout this podcast series, you'll hear from doctors, nurses, research scientists, administrators, other caregivers, and people living with dementia about how cannabis helps.
Like it did for our family.
That's right.
After my mom was diagnosed with dementia, we were thrust into family caregiving and became fierce advocates for people living with dementia,
including their access to cannabis medicine. Dr. Yafai is an emergency medical physician who transitioned into cannabis-based medicine. In 2017, after adult use marijuana laws had passed in California, Dr. Yafai opened her private cannabis clinic, the RELEAF Institute, where she sees patients referred by physicians for cannabis education and treatment. Roughly 75% of her patients are over the age of 50 and prefer to use non-smokable cannabis products.
Dr. Yafai is the co-vice president of the Society of Cannabis Clinicians, the director of research and development at High Sobriety, a member of the UCLA Cannabis Initiative, and speaker for UCSD Center for Medical Cannabis Research. In 2018, she was accepted as an adjunct professor at John Wayne Cancer Institute, working with cannabis and cancer research.
Dr. Yafai works to educate physicians, clinicians, and other healthcare providers on the most up-to-date clinical data and research in the field of cannabis.
And we are so excited to be talking with Dr. Yafai about how cannabis helps dementia. Thank you so much for taking the time to be with us today.
Thank you for having me. This is such a great venture to go on with you both.
Awesome. Thank you. So we all live in LA, and it's a very dynamic time, to be sure. The thing is that no matter what else is happening in the world, dementia doesn't care. It marches on. And people in relationship with dementia don't usually have the luxury of choosing what to focus on. Dr. Yafai, can we talk about how cannabis helps ease anxiety in people living with dementia? Maybe tell us about some of the mechanisms by which cannabis helps to relieve anxiety.
Sure. So what we're seeing generally in the clinic today is a variety of different things. So the question becomes, which chemical is helping ease anxiety? And for each individual, we've seen that it's a little bit different. There's some studies and research out there that looks at CBD very specifically as the major chemical component as quieting anxiety. There are some studies that are looking at THC as the major component to quieting anxiety. And what we see, what we know is that everybody responds to this a little bit differently. So part of that is also what we're allowed to do research on, and this is a really challenging time for a lot of scientists and physicians right now because we keep wanting to go to the scientific literature to say, okay, let's prescribe or let's recommend, chemical A or chemical B or a combination, and we're really stuck because the federal government has created this really awkward place where we can't do great research or gather great data because of the rules and regulations there. So one of the studies that we're looking to do right now, and I think I mentioned this to Chella before, is looking at anxiety in patients with Parkinson's disease. And Parkinson's disease and dementia actually tend to be a little bit intertwined because we know that Parkinson's patients have a higher tendency or rate of dementia than the average individual. We also know that Parkinson's patients have a higher tendency towards anxiety, and that sometimes anxiety can come up about 5 to 10 years before your Parkinson's diagnosis. So all of a sudden, in your 40s and 50s, you're now dealing with a lot of anxiety issues that usually in your 40s and 50s, it's not the time where people get diagnosed with new onset anxiety. So now we're taking a look and moving forward, hopefully, with a study looking at CBD very specifically as a means to control anxiety, specifically, again, in Parkinson's patients or Parkinson's-related anxiety. So it's really nice in dementia to be able to use something during the daytime where we can look and see if we can help patients with dementia control this mild anxiety that they all kind of tend to exhibit. Because sometimes they look around themselves and they don't know where they are, they don't know who they are, they don't know who they're with, and that can be anxiety provoking in anyone.
Sure. Yeah. We've recently heard that CBD in low doses can be stimulating in some people. What do you know about that?
Absolutely. I refer to CBD as like having a cup of decaf coffee. That's my usual analogy because I do find it to be awakening. And that it tends to be, I think of, if we think of sativa and indica, those kind of ideas of what cannabis makes you feel like, sativa tends to be a lower THC content and maybe some more CBD in it. Whereas indica tends to be, a heavier THC content with some other terpenes, linalool, limonene, those other things that tend to be more calming or sedatives. But yes, CBD absolutely can be awakening, even if you think of it as calming your pain that makes you feel lethargic and makes you feel like you can't get up and move. We have patients with arthritis who are like, I don't want to get up and walk because my joints hurt by the end of the day. So it just makes me feel a little bit more tired. But when they use CBD-based products, we find they can get up, they can move more, and they feel energized just by means of being able to do those things.
And there seems to be a lot in the press right now about arthritis and possibility of using CBD, and it sounds like that really might be, although I suppose it has the anti-inflammatory properties of it, but that sort of disassociative stimulating effect that gets you through the pain is maybe part of it too, right?
Correct. So there's a really great mouse model that took a look at arthritic mice. And what they did was they took a look at, I believe, 4 parts, if I remember correctly. One was the size of the joint. So I'm showing you like the circle diameter of the joint. And then there was also the amount of pain that the mice were in by means of movement. And then afterwards, they unfortunately always sacrifice these mice. And then they take a look at the actual joints and the inflammatory markers in the joint. And on all of those parameters, they used topical CBD actually in mice. And in those mice, they found a great reduction in all 3 of those parameters. So they could say with confidence, at least on preclinical models, that CBD is very helpful in mice models of arthritis. And with my patients as well, things like a topical CBD combined with an oral CBD does really well for a lot of arthritic patients. And I like to consider it as sandwiching the pain. So you can get around it both from your blood and then from the top where you get really into the joint where there's not a lot of great blood flow sometimes, especially with arthritic patients. So you can try and get it to your joints from both directions.
Awesome. What sort of dose is an average dose? Is there an average dose for CBD orally for arthritis?
Chella, that's a great question. So this is a big topic of discussion. And actually, I'm going to take it back to a NIDA-based discussion. So the National Institute of Drug Abuse recently put out an article and said, I believe it was Laura Volkow, if I'm not mistaken. She put out an article and said, hey, do we need a standardized dose for THC, CBD? Do we need to have these kind of standardizations and dosages? And absolutely we do. Just like we have standardized doses for Tylenol for pediatrics, acetaminophen for adults, and any sort of NSAIDs for adults and children. And we need to really draw a line and say, hey, for pediatrics, we really need to go weight-based dosing like we do almost all other medications. Whereas for adults, we can really have a little bit more of a window. We need to have discussions about weight versus gender. We know Ziva Cooper has done a lot of really good research, and I believe she's undergoing another research grant-based approved research on gender differences. So women absorb this differently than men do. We absorb it differently with and without food. So with food, you absorb more of it. Without food, and a lot of people on the internet and a lot of the general public who are cannabis aficionados, they all say the same thing. It definitely hits me after I eat, X, Y, or Z.
Like the mango myth.
Right. A lot of these myths are based, loosely on something, right? Some kind of truth. Right. And so, there's a reason why it's mixed into chocolate, right? It's a nice fatty base oil, a nice fatty based product, and we absorb it better with fatty based foods. So that's a really great reason to use chocolate. as your base, right? There's a reason why it's not mixed into Quaker oats, right? It's because it's not going to get absorbed. And trust me, people have been trying this out, left and right in every which way possible, because the best part about cannabis is the fact that we have millions of people who have been putting in their own creative juices in this and have really been bringing up the game without us even trying, right? Without even having scientists involved for so many decades and centuries. We've really been able to get to this point where, hey, there's a reason why, we can say actually that CBD, if you've kind of overdosed or taken too much THC, maybe you should try having a little bit of CBD tincture on top, and it'll dampen the effects of the THC. I mean, I first read that idea on some blog post somewhere. And in fact, you see it play out in medicine. Right?
Really? So that's a measurable effect that you can see in people. It will counteract that paranoia or that overstimulation of from the THC.
Absolutely. And it works really nicely in all these different ratio meds where if you use 20 parts CBD to 1 part THC, you're not going to feel the THC, right?
Right.
If you use a 4-to-1 ratio, 4 part CBD to 1 part THC, you're not going to feel the THC in it. And it's because it has this dampening effect on the THC. Now, that being said, if you've taken 20 milligrams of THC and you're a novice user, and you want to try putting some CBD in you probably aren't going to be able to get enough CBD in you to counter those effects. And you probably will need a little more help than the average bear. Which in that case, I would suggest going to the emergency department and getting pharmaceutical-based medications to quiet that down.
If that's what you need, yeah. Well, that certainly seems to be what you're seeing as far as an increase in emergency room visits in the legalized states. Are these new people who are trying a little bit too much than they should, haven't gotten the right advice, and they end up with a little bit too much overstimulation and end up in the emergency room. Always go home eventually, safe and alive. But it certainly can be disconcerting if you're not used to it or not aware that it's coming, and blows many people out of the water. And it turns out, looks like Brownie Mary might have been right all along with a little bit of chocolate brownie to get your medicine in most effectively, right?
Right, that's exactly right. So the key here is a little goes a long way.
Well, that's actually what I wanted to ask you about. We recently spoke to Eloise Thiessen, nurse practitioner, and she has been working with a number of dementia patients. And we'd like to get maybe an idea of some of your anybody specifically in your case practice. And she's been using extremely low doses to great effect as far as THC and even CBD. But THC at super low doses she is finding very beneficial. Can you talk about maybe one or two of your older patients who might be suffering from dementia and how you find their dosing and what's most effective for you and them?
Yeah, absolutely. I was thinking about one particular dementia patient. He was an 80-year-old gentleman, or is an 80-year-old gentleman who had recent hip surgery after he had broken his right hip. And this is really common. We see dementia get exacerbated or worsened after surgical procedures. Yeah. And the anesthesia kind of leaves your mind worse for the wear afterwards. Right. And so what happened, he came back home from surgery and was up and walking, but became hyper-aggressive, became very difficult, was combative and even a little bit physical with his daughter. And so it was really difficult because everyone wanted to help and it was hard to help. And it turned off his daughters from wanting to come over, and it turned off, and so it becomes more isolating. And they tried to kind of do it on their own with cannabis, and they had a really difficult time, so they came and sought some help. And what we found was very quickly, you could use about, when we're talking about dosages, I find that about 20 to 30 milligrams is going to be about a standard adult-sized dosing to start. For the daytime usage, but that's something really that you want to be conscientious of other medications that are involved, what else is going on in their lives, etc. And that's where the good history and physical exam comes in. And then, so we adjusted to start him on some CBD during the daytime to just give his mind a little bit of calm and peace. And then switched over to giving him a little bit of THC at nighttime. And a little bit is really you're talking about 0.5 milligram of THC to 2 to 3 milligrams of THC.
Yeah, that's the dosing that Nurse Thiessen was talking about that was really kind of remarkable.
Yeah, right, exactly. So when NIDA, or National Institute of Drug Administration, when they're talking about, standardizing THC dosage to 5 milligrams of THC, we have to be able to say, hey, that may be for a 20-year-old a standard recreational dose to get them to hallucinate, get them to feel good, get them drunk, right? In essence, because that's what they're looking for.
Right, some type of intoxicating effect.
Right, because that's what a 25-year-old, let's keep it within legal limits, a 25-year-old is looking for. But when you're talking about an 80-year-old with dementia, you do not want them to hallucinate. You do not want them to be unstable on their feet or feel wobbly or feel drunk, because they will fall and injure themselves.
Mm-hmm.
Right.
And so that's where we really have to create this divide between what are we talking about medically and what are we talking about recreationally. And we need to create an understanding that the two are not the same.
Mm. Certainly, it has to do with probably intent and goals, essentially. And it's just, I find it fascinating that, if compare, they love to compare cannabis with alcohol, and it should be regulated like alcohol. But nowhere in the world, I guess back in the day, people were like, "Oh, alcohol is good for you. use it for this." But it's
They still are.
and they still are. But here we are. If you use this tiny amount of dose, it's medicinal value. And but if you want to have a good time, you just add this much to it. This experience, you get this, and they're both beneficial to some degree, whether it's relieving anxiety or you getting that euphoria that it lifts your life, or gets you to a point where you're no longer agitated and you can sleep, and you can and we also got that information that you don't necessarily want all dementia patients on a high dose of THC. Especially at certain points of the dementia, where they're already being challenged by stuff going on in the brain that's not necessarily normal, that they can understand.
Them hallucinating because it may make them feel even more agitated and even more aggressive. Right. And so going back to this patient of mine, the best outcome of this was that we got him to a place where he was feeling good, not being physically aggressive with his daughters, and they could rekindle their relationship and really allow for him to have more of a normal interaction with his intimate family.
That's so important.
It was such a blessing. And then at the same time, we could limit the amount of psychoactive medications like Haldol, like Ativan, like Benadryl, where these things are, they would knock him out for hours on end, and the family didn't love that either. And I mean, nobody does, right? You don't want mom or dad to be gorked. You want them to be at their best.
And falls too. Falls are part of that as well.
I'm sorry, could you tell us again what dosing this particular patient was using?
Sure. So he was on roughly 30 milligrams of CBD about 3 times a day, and about 1 milligram of THC at nighttime.
1 milligram, that's amazing.
Yeah, so he just needed kind of a touch to help him fall asleep and just not get agitated. Yeah. So I mean, and that's the key is figuring out, I always say the whole idea of a little is start slow and start low and go slow, or the other idea is a little is good, a lot is better, is only for recreational users. That idea that the cannabis industry has been propagating is really just for recreational users, because otherwise we really don't want patients on a lot because of exactly the things we've mentioned: falls, hallucinations.
Definitely not our patients.
Yeah.
Yeah. And the other options too are there's these nice ratio mixes, right? So we have some dementia patients who are in hospice or are dealing with end-of-life issues. Yeah. And then it becomes another question or another layer. Do we want them using Ambien every night? Do we want them knocked out stone cold so that they can't interact with their family members, or the caregivers who are helping them out? A lot of times they don't like patients to be gorked or drooling or sedated all day, because then you do develop some nighttime issues about them not being able to sleep at night. So we want our family members, our patients. We want everybody to be awake during the day, interactive, moving. We want them exercising. We want them engaging with other people to enhance all those other endorphins, right? All those other things that give us happiness and bring to life good things.
Yeah.
And then at night, to be able to get good, restful sleep.
Mm-hmm.
Now, nighttime THC is another hotly debated button. People always say, oh, well, you can use CBD for sleep. And I know there's a lot of conflicting research out there, and there's a lot of conflicting discussions amongst us as cannabis providers as to what's the best way to do this. And I think that is still going to be something that we're going to continue to need really good scientific evaluations, because there's a lot of individual discussions going on, and a lot of, what's the right word here? A lot of manufacturing of data to say my product is better for this.
Right.
So that, and we don't want that to cloud the issue. Whereas that wasn't necessarily clouding the issue beforehand, because people were just using flower from the earth. Now we have a lot of product lines.
We have isolates. We have my isolate's better than your isolate. Mine's nano. Yours is not. All this fancy technology that's going to save us.
Mine is whole spectrum. Yours
right.
Right.
Hemp, not hemp, and then you've got one of the trends that I kind of am seeing is that to use CBD alone, like look at Epidiolex, you have to use it in such high doses to make it effective that then it starts to become that toxic medicine that it might create problems.
That's right, and so it's all and we talk about this all in isolation, but what I find is that when you hit, I'll give you 40, 50, 60, you're probably taking 1, 2, 3, 4, 5 medications on your individual genetics and predisposition and everything else that goes along with it. And depending on that, how is that going to interplay with cannabis? I find that we don't talk about that enough. We only talk about this in isolation. But hey, maybe you have, my dementia patients are never on nothing. They're on at least a blood pressure medication.
What was your patient that you were talking about earlier on, the one who had the hip replacement?
Right, so he was on blood pressure medication. He was on some Haldol, and that was the medications we wanted to reduce because it wasn't beneficial to him. Right. And he was throwing away his pills, so he wouldn't take his pills that he needed. He was in pain as well, so he had some narcotic pain medication that he was refusing to take as well. But he wasn't able to move because he was still in pain. So it's being able to adjust some of these medications. So no, you don't have to take your narcotic if you're in pain. You can use this in place, and we can supplement this. Yeah. But at the same time, not everyone's telling their patients this because they're not all mindful of cannabis being on board. Yeah.
Right.
So one of the things that we need to really educate our practitioners on, and our physicians and our medical providers who are writing regular prescriptions, is, hey, listen to your patients. If they're planning on returning to use cannabis, this is important, and you want to reduce the amount of narcotics that you're prescribing for them, because I'm going to mention Ziva Cooper again. She's done some really great research. Ziva Cooper did a great article on showing that you could use 50% of a narcotic plus THC and have a synergistic effect on pain.
Awesome.
That's, every doctor should be on board that. And I know the pharmaceutical industry is not going to be on board it. And that's probably because there's a lot of incentive there with doctors to not look at those other options and cutting down on pharma. That is so huge. Go ahead.
Why?
I'm going to step in for just a moment. So it's not about incentives for doctors. It's just lack of knowledge.
Right.
Why is it that there's a lack of knowledge? Why aren't they teaching this in school?
Right. Because we're not teaching this in medical school. We're not teaching because it's a Schedule I drug. I mean, and let's go back to what's going on in the outside world today, not to date when we're recording this, but we are actively having, protests, riots,
uprisings,
of it, and the Black Lives Matter movement, which is, near and dear to my heart. And one of the reasons it's near and dear to my heart is because of the fact that the cannabis movement came out of this. Yeah. And let me backtrack and explain all of this. So in the early 1900s, the reason why cannabis or marijuana was prohibited was directly related to African Americans and Hispanics, specifically Mexicans. Okay, so let's go back and talk about why this all happened. In the early 1900s, like 1901, we were using cannabis in pharmaceutical medications. I think it was Eli Lilly was using
at its own farm.
And it's right, and their own farm, and it was actively being put in, sleep medications, cough syrup, everything, and then some. And then around the 1920s, we now have Mexican immigrants. We have a lot of movement in Black America. And what happens is that we start labeling cannabis as marijuana, which is the term that Mexican immigrants use for cannabis. And what we start seeing is there's all this propaganda about how it makes Mexicans crazy. It makes African American males violent and prone to raping white women. This is where all of this centers around. And we created this sense of, and this really horrible idea that African American males are violent, aggressive, and rapey. I don't know a better word for that. And that Mexicans are crazy. And one of the reasons why is because of cannabis.
Right.
And so all of a sudden we see the Marijuana Prohibition Act coming into play in the 1920s. And all of this stems from complete and utter racism. And it has come through even till today, where we're seeing these things open up, and we're seeing recreational and medical laws open up in all these different states. We now have 11 states that are recreationally legal to use cannabis, and we have 33 states that have both some type of medical laws for cannabis.
Right.
What is still going on today, and there's this great UCLA research on this, is that African Americans are still 3.6 times more likely to get arrested and put in jail for possession of marijuana.
Yep.
And this plays into, Black Lives Matter, because why are we imprisoning people? We can imprison white Americans, we can imprison anyone, right, for this exact same things, but we're not seeing it. We're seeing it disproportionately done towards our Black American companions, our Black American citizens, and this is not okay. This is something that has propagated the idea of, I'm disheartened to report this, but one of the things I hear is, George Floyd died because he was intoxicated, and we see plenty of people. I work in the ER. I see people come in drunk, intoxicated, high. You name it, I've seen it. Night and day, we take care of those people because we understand that this is, number one, an illness, right? This is, number two, it can be accidental. And number three, it's not hurtful to other people, right? It's hurtful to oneself. It's not hurtful to somebody else.
Yeah, you ever seen Philly after they win a big game? There's a lot of drunk, angry white people or happy white people out in the streets causing mayhem.
That's
so,
right.
and a couple of points on what you mentioned is, and that, tying it to what's going on this week, public consumption of cannabis, although it may be legal in 11 states, public consumption is illegal. So if you're at these marches, if you're at these things, someone brought up, said, they're going to use that excuse. If you're smoking weed, they're going to use that excuse to detain you or otherwise use their police powers. And also, Alex Berenson, one of our favorite prohibitionists currently, it was directly correlating cannabis use to what's going on in the streets right now, which is complete nonsense and a continuation of how we got to where we're at today. So you have both points taken to see where we're at. And policing in general was created to control blacks, slaves that are based or non-slaves, to control the escaped slaves and the black population. So we have a history of where policing came from, expanded in the drug war. You hadn't even gotten to the drug war in the 70s.
Let it go.
Yeah.
I mean, there's so much that we could talk about and how this is all interrelated into one another and how unfortunate it is. And, I'm so torn with everything that's going on about how to help and how we can all be a part of this. But I think the most important thing we can do is acknowledge, where this all came from and how it's changed, the perception of cannabis, how it changed the perception of marijuana, and, whose backs we're stepping on to get to where we are today. we've stepped on people's backs to get here in the cannabis industry. And it's important to acknowledge that. When I first started in all of this back in 2017, right after legalization here in California, I remember going to a big cannabis conference in downtown LA, and there were about 1,000 people, almost all white American, great people, wonderful people, but there was probably about 3 to 5 Black men. There was one Black gentleman that was a very famous person that was encouraging use of a brand, and then there was about 4 or 5 others. Now, I was leaving this conference, and I took an Uber back home. And in the Uber ride, we started chatting, and it was a Black gentleman who was the driver, and he was like, "What were you doing?" And I was like, "Oh, well, interestingly enough, I was at a cannabis conference." And he said, "Oh, you got to be careful. They'll put a Black man in prison. Half my relatives have been put in prison for that stuff, so I stay as far away from it as possible." And you will never, ever hear that discussion in white America. You will never hear that kind of fear in white America about using pot, right? There's no fear about smoking pot. There's no fear about, oh, my cousin was put in jail because he smoked pot and the police caught him. Mm-hmm. I can tell you how many college friends I had who were smoking pot in high school, and there was zero fear that they would be imprisoned for it. Zero. And yet, a gentleman on the streets, just a regular old conversation, and it was palpable how his fear was around this, even though it could be beneficial to his, potential future.
Yes.
It's a potential medication.
Exactly. I was going to say for his health.
Yes.
Black and brown people and women are disproportionately impacted by dementia. And if we could get the propaganda broken down, the stigma broken down around cannabis, we might be able to get them more help.
Right. And I think it takes things like this podcast to shine a light on where it can be useful and where we can actually reduce other medications that are harmful to patients, right? We for a lot of years, we've been talking about the opioid epidemic and the solution or a cure for the opioid epidemic. And this is staring us in the face.
Oh yeah, it's so much. There's so much science is coming through about that. Every state has.
Well, not fast enough.
I know. It's just, it's not really science. It's just the statistics of the numbers of how the opioid prescriptions are dropping in the states where it's legal and medically or recreationally. It is staring us right in the face, and it's just criminal.
Our elderly population are disproportionately at risk because they tend to have more issues that require narcotics. We've all had to implement in our hospitals, safety and precautions around using narcotics for pain because we've seen overdoses happen, even in the hospitals, even where we're being safe, because this is inherently not a safe medication, and yet we use it like it is. So, shining a light on these things again, New England Journal of Medicine and JAMA, these are 2 big scientific journals. I personally have submitted an article of a clinical case presentation where we were able to take a patient off of 180 milligrams of morphine milligram equivalent. Okay, it's a lot of painkillers.
That's a lot.
60s, and they were all prescriptive medications, and using non-inhaled cannabis to take him off all in 3 months. Now, and then what ends up happening? So here's kind of the catch-22 of it all. The vicious cycle is that I submitted this highly scientific, through a medical doctor's office article to these 2 reputable sources. And both of them dismissed the article summarily based off the title. Okay. And the idea that we can dismiss this. And then, what ends up happening is when I talk to my colleagues, my physician colleagues, about using cannabis as an alternative for pain management, they all say the same thing. Well, where's the science? Where's the data? Where's the literature? And then it's, there is no data in science and literature because they won't allow us to publish it. Yeah. So, and then you go one step further and you say, well, on a national level, they won't allow for, more research because there's no individual case presentations and there's no clinical case studies presented in any of the literature. And you say, well, that's because the individual cases are not being allowed to be reported. So how is it that we're going to change? And at some point, someone has to say, hey, there's got to be a change here. And, you know, I'm really thrilled to say that UC San Diego has been making these changes one article at a time. UCLA is starting to make those changes and making those waves. NYU with Dr. Yasmin Hurd is starting to make those changes, looking at CBD for treatment for heroin withdrawal. So we're starting to see some of this data and literature. In Germany, there's actually some great research coming out about mice models and Alzheimer's disease, and maybe preventatively using cannabis and THC very specifically for dementia treatment. So anticipating dementia and preventing it from even coming on to the same degree. And the most interesting part about that data is hey, you don't have to get these mice high all day, every day. You can just use small dosages, number one. Number two,
like a vitamin.
Right. Or the other idea is, hey, maybe we need to talk about brains being different as you age. Maybe the young brain is different from the middle-aged brain, which is different from the elderly brain. So maybe we need to start talking about our brain doesn't stay static after 21 till 100, right? I mean, like, nothing else in our bodies do. My boobs sure don't. So that's one example. But,
on a side note.
I mean,
everything changes.
That our bodies, you know, stay the same from the age of 0 to 20, or are growing between 0 and 21. And then after 21, we stay stagnant or static is false.
And your brain is right. As soon as you're like 20, your brain is already starting to shrink.
Right. And so you're getting this idea of, like, you know, maybe we need to take a second look at the second phase of life, right? Maybe we have phases to life, and our bodies and our organs and our different structures aren't just, you know, one shot fits all. And so maybe we need to take one consideration for up until 21. We need to take a different consideration of, maybe let's throw out a number, maybe after 45. Maybe that, I don't know.
For me, it was 42, just saying.
Right. And maybe we just need to start taking a second look at these things. And maybe we need to start throwing ideas out there, because we can't progress unless we have ideas that will be heard. And these ideas need to start percolating, and we need to start having discussions, and we need to start getting these ideas to the right people. Right people need to hear them. And we're starting to get a little bit of that, and we're starting to hear some responses, but it's not there yet.
Well, you know, the one of the powers that be have the ears of the prohibitionists and the pharmaceutical companies, as opposed to the really knowledgeable clinicians and folks that are actually trying to create educational programs for clinicians and, you know, certified programs so they can actually get the knowledge that they need and spread it out to the people who need it. So yeah, we've got this wall of information. You know, just recently this week they were talking about how they've, you know, under the Trump administration has been secretly working on ways to make sure prohibition stays in there, you know. So we don't have their ear. We need to get in there. We need to get somebody in there to actually give them some real information, you know. And ironically,
personal experiences.
Yes, exactly. You know, Kim Kardashian needs to be making some phone calls, you know, about
what you're talking.
Right. It's exactly. Why not? You know, I could just see Trump coming out and saying, look, CBD cures the COVID. I don't know if that's going to be a good thing or a bad thing for CBD. But, you know, I could see him saying that. But yeah, I think we need to get more knowledgeable and real clinicians that are actually using this. I mean, CanMed last year was great because, well, it wasn't, I mean, it was a lot of research, talking a lot about mice, which is wonderful, but there was very little clinical presentations. And this year, it looks like we're going to see some clinical presentations on dementia, which is super exciting. So I think really the practical use of it on the ground with doctors like you and institutions. Chella, please.
The change you're talking about is descheduling, or at least rescheduling.
Well, and I'll go one step further, because heroin is a Schedule I drug. We've got plenty of research on it. It's
right.
Not, right. It's not. I hear you. I'm not dismissing that at all. I totally agree that we need to deschedule it. But even in the states where it's recreationally legal, we still don't have really good, you know, powers that be. So here in the state of California, the Bureau of Cannabis Control has got nothing to do with medical use. Literally nothing to do with medical use. on a committee of 22 people, right, on their consulting committee. They've got 2 doctors, okay, both of whom have, like, I venture to say how much clinical experience they have, okay? So we need to start even here, right? Even here in California, where we think we're super progressive, and we've got no medical protections in place here in California for patients. So patients are still paying 25 to 30% taxes on their medication, where they pay 0 taxes on a pharmaceutical prescription medication.
It's been medically legal since 1996, yet our state schools don't teach about it.
And so it's like, it's all of these layers. We have, you have to go to the public health facility to get a second recommendation, basically, from the public health department in order to get a decrease in taxes. What other medication do I make patients jump through so many hoops? After I prescribe Viagra, do I then make them go to the public health office and have them file with the state that they are using Viagra?
That would be funny. That would be funny. That would be good. That would be interesting.
Can you imagine the outrage of Viagra? I mean, which is 100% purely recreational for purposes. I mean, it is for no other reason, right? So
wow.
I mean, if we compare these things to the right analogies, right? We don't have people, even in the state of California, appropriately addressing this. The Medical Board of California, as wonderful as they are, and I really think Kim Kirchmeier has done an amazing job in terms of, allowing for a lot of cannabis flexibility, I think there's a lot of room to grow. And I think somebody has to take ownership between these 2 groups, between the Bureau of Cannabis Control and between the Medical Board of California. Somebody has to take ownership for cannabis regulations in the medical field, and nobody has.
Well, they've, 64 destroyed medical, and I'll turn it over to Chella. It's 64 destroyed medical. The legalization that Dennis Perone did in California destroyed it. And now what we have is in order to get a card, it's so difficult to go and get a card. It's costly. I mean, the number of qualified medical cannabis patients is like 6,000 in California, or some absurdly low number that actually have a card that saves you that taxes. So yes, absolutely, we need to fix medical in California.
What I'm afraid some medical patients might be doing to save on taxes might be going to unregulated places.
Which is all the BCC is obsessed with right now. They're hiring enforcement people to bust all these black markets that the medical people are going to because they don't want to pay the taxes.
Traditional market,
yes.
So that's, this is another important thing, is that medical patients, this doesn't get covered by insurance. Right. They're paying now, and they get expensive. So for somebody who's using, let's say, 30 milligrams of CBD 3 times a day, that's what 3069. That's 90 milligrams of CBD a day in a typical 1,000 milligram bottle. Right, you're going through that in roughly 10 to 12 days. And that costs anywhere from $75 to $100. So you're talking about medication that now they're going to use $300 worth of medication in a month.
Right.
Most people, that breaks their pocket. I mean, listen, if I was going to use a medication $300 a month, I'd think twice about it. I would go with the Ativan pill that's $2 with my copay. I'd go with the Norco that's $5 with the copay for pain. Why would you necessarily go use something else that costs so much? And so it's really challenging for my medical patients. And it's important that this is brought to the forefront of the discussion, right? We don't just want to deschedule or we want to do it the right way. We want to have our medical professionals at the front lines of this and talking about how it's beneficial to their patients, but also how they are overall healthier and how this is difficult to maintain because of the cost. And so this is something that all goes hand in hand.
And then again, also disproportionately impacts Black and brown people.
Yes.
With less access to cannabis.
Yeah, and poverty. Yeah, if you can't afford it, it's automatically it's limiting who can use it.
Yes, absolutely.
Dr. Sherry, you're such a wealth of information. I really appreciate you coming and joining with us today. I hope to have you back again. I don't want to take you any longer.
Yeah, we could sit here all day.
We really, really. It's not easy to find a healthcare professional with this specialized knowledge. Do you take telehealth patients?
Yes, I take telehealth patients. I have patients as far as New York, down to Florida, and up to about San Francisco.
Awesome.
We have had a couple international patients come in and have just educational discussions. But yes, we take telehealth patients, especially now during quarantine. We've optimized our telehealth care. So by all means, if you have questions, concerns, if you want to do this better, if you want to learn how to minimize your medications and use this as an alternative base, hemp CBD is legal in all 50 states, which is such a bonus and advantage, especially for patients who want to start and don't know where to start.
And where can they find you?
Oh, great. Thanks. Thanks for prompting me. You can find me at the Relief Institute. Relief is spelled with a leaf, RELEAF. So that's www.thereliefinstitute.com. Or you can email me directly at Sherry, SHERRY, at mdrelief, RELEAF.com, or 310-475-2626. We look forward to helping you out.
Awesome. And we'll have all those links in our show description as well.
Great. Dr. Sherry Yafai, thank you so much for all of your work and for joining us on Cannabis Helps Dementia. And we hope definitely to talk to you again, especially as the results of you get your study going, and as the new results come in from Germany. We'd love to talk to you about that as new information comes in and we learn more about how cannabis can help dementia. I mean, the pandemic goes on. The people are in the streets for justice, but Alzheimer's and dementia continue as well, and people are in need in these times more than ever, especially not just people with dementia, just people that are anxious and full of anxiety. Cannabis is an option, and it's great to know that people can contact great doctors like you who know this and can guide them on their journey with plant medicine.
Cool.
Thank you. Awesome. Thank you so much for having me on. Thank you for doing this. This is great.
Of course. Thank you.
Thanks for joining us for Cannabis Helps Dementia. Be sure to download and like us on Spotify, iTunes, or your favorite podcasting network.
And please share this podcast with anyone you know in relationship with dementia.
Do you want to tell your story of how cannabis helps dementia? Visit Anchor.fm/Cannabis Helps Dementia to leave us a voice message, or drop us a note and connect with us on the socials.
Check out the Society of Cannabis Clinicians website to find real medical professionals familiar with cannabis medicine in your area.
Because you remember, we're not doctors.
Just family caregivers turned advocates.
And don't forget, download, like, and share what you learn. Cannabis helps dementia.
Why don't you get wise? Get up and get out. Get rid of that frown that's been dragging you down, and get up in the air. Just pretend that you can fly. You'll never know if you can till you try. So get out of your rut. Be able and strong. Give vent to that intent you've had pent up for so long. Come on up and sing.